Hello, my name is Dr. Jonathan Jones. I'm a rheumatologist with Samaritan Rheumatology. This is the next installment of Rheumatology Basics for residents. Today we're going to talk about the ANA associated diseases. Now before we go to the next slide, I want you to pause and see if you can remember the 5 main ANA associated diseases we've talked about. And you'll remember that there's 3 S's and 2 M's. So pause now and see if you can remember them.
When you think of the ANA-associated diseases, these are the first 5 that you should think of. The systemic lupus, Sjogren's disease, systemic sclerosis or scleroderma, mixed connective tissue disease, and myositis. Now I want to be clear that these are not the only ANA-associated diseases. In fact, Hashimoto's thyroid disease often is associated with an ANA. You can see an ANA in things like rheumatoid arthritis or autoimmune hepatitis. But these are the main ones that I would have you think of. And when you are planning to order an ANA, you're usually going to think about these 5 diseases to help gauge if a positive ANA will actually lead you towards one of these diagnoses. Now, an important part about the ANA that you'll recall from our earlier lecture is that this is really just a screening. All we have with an ANA is we know that some antibody sticks to something within the cell, but we don't really know what the antibody is sticking to. The pattern that's described on the ANA is most often homogeneous or speckled. And when that's the case, it's really hard to know what the specific antigen is. There are some cases where the ANA pattern is very helpful. For instance, if there's a centromere pattern, then that person almost certainly has an anti-centromere antibody. But let's think about the most common antigens that are associated with an ANA and what association those have with specific diseases. Here is a listing of the more common specific antigens or specific antibodies that are seen associated with a positive ANA. This is also not an exhaustive list. There are some others, but these are the most common ones. And the important thing is that these antibodies, when present, do lend some specificity to the disease that may also be present. What I would encourage you to do right now is to pause the video, look at these antibodies, and see if you can remember which ones associate with which disease. Were you able to remember which ones go with which? Let's see if you were right. These are the antibodies that most closely associate with the specific diseases. I want to emphasize here that just like with so many things in rheumatology, nothing is absolute, and there certainly can be some overlap. For instance, having a positive Rho antibody or SSA antibody is certainly most commonly seen in Sjogren's disease. However, that can also be present in lupus or myositis. Similarly, you might have an SCL70 in someone with lupus, or you might have an RNP antibody in someone with myositis. So these are not perfect. However, if you are able to remember these associations, you're going to be right in predicting the disease most of the time.
In the rest of this lecture, we are not going to talk about myositis. That's going to be a separate lecture of its own. We're going to focus mostly on how to recognize these diseases. Your main goal as an internal medicine doctor is to be able to make a diagnosis, to know when you should be suspicious for one of these diseases. So we're going to focus mostly on systemic lupus. We're going to talk a lot about Sjogren's. We're also going to talk about how those two often have overlapping features and how we might distinguish them. And then we'll talk a little bit at the end about how to approach treatment for some of these diseases.
The most common ANA-associated disease is systemic lupus. We're going to start with this disease. Now, you will remember that systemic lupus is one of these illnesses that can have so many different manifestations. It can affect almost any organ system. And this is one of the reasons that diagnosing lupus can be challenging because of the many varied ways that it may present. This also becomes challenging when someone has a diagnosis of lupus, because now when they get sick, it's sometimes hard to know if whatever illness they're experiencing is related to their lupus or is a different process. When you are thinking about lupus, I mostly want to help you think about how to recognize this disease and help in making a diagnosis. Now, it's true that it can affect almost any organ, but I want you to think about the most common organ systems that are involved in systemic lupus. And in my opinion, the 5 listed here are the most common ways that lupus is going to manifest. Let's start by talking about the skin. The first point I want to make when thinking about skin manifestations of lupus is to first make sure it's clear to you that some patients only have cutaneous lupus. This is one of the reasons why we have the distinction of systemic lupus versus cutaneous lupus. Many people who have the skin manifestations will only have the skin manifestations, especially the chronic forms such as discoid lupus. In fact, it's because those patients with something like discoid lupus so very rarely have systemic lupus that I hardly ever see it. Most of the time, these cutaneous manifestations are going to be managed by dermatology. However, the acute forms of cutaneous lupus are commonly seen in systemic lupus. And so we're going to talk about 3 different subtypes of cutaneous lupus. When we think about acute cutaneous lupus, this is something that fluctuates and is not present for prolonged periods, although it could be. For instance, the malar rash will often come and go over a period of days, though it could be going on for weeks. You'll recognize the malar rash as what is often called the butterfly rash, which is red, often some in duration, and can also be quite painful. This rash classically spares the nasolabial folds and is often quite prominent. Now, this malar rash becomes challenging because it's very often for people to get red cheeks. We see this a lot with rosacea. Sometimes people just get a flush when they exert themselves or get stressed. And I've had several patients who will take a picture when they're stressed out and they have this vascular flush and claim that they have a lupus malar rash. And honestly, sometimes it's hard to tell. But again, most of the time, a malar rash is inflammatory, and so there tends to be some induration and some sensitivity to the rash. What about sun sensitivity? Now, I want to clarify here that sun sensitivity does not mean that you burn easily. It's more of an allergic reaction to the sun. And when you talk to patients with lupus, it's really quite striking. Some of them will be in the sun for only 10 or 15 minutes and then get a terrible rash on sun exposed areas, and it can be very itchy or very uncomfortable. And for this reason, many people with lupus will try to avoid the sun. There are clothing stores specifically for lupus patients where they make long-sleeved UV protected shirts, wide-brimmed hats, etc. to try and protect against that sun sensitivity. The second form of cutaneous lupus that we'll talk about is subacute cutaneous lupus. This is usually going to be persistent for several weeks and can be widespread or fairly localized. If you look at the bottom picture, you'll notice that subacute cutaneous lupus sometimes is going to look like ringworm, a fungal infection, or maybe even eczema. Now the top picture looks much more impressive, but the point here is that oftentimes a diagnosis is difficult to make without a biopsy. But the biopsy will show characteristic features suggesting that it is a lupus rash. I do want to thank DermNet, which is an online website with pictures for these images. If you want to see more images of any of these cutaneous lupus, you can go to their website for more pictures. When we think of chronic cutaneous lupus, there are several different forms, but the most common one that you'll hear about is discoid lupus. Discoid lupus forms these very inflammatory lesions that are often discoid. They can be throughout the body. Oftentimes they're seen on the scalp, and when on the scalp, they will frequently cause scarring and hair loss. Here again, discoid lupus is rarely associated with systemic lupus. If you see a patient who has cutaneous lupus, it's still important to do an evaluation to see if they have evidence of systemic lupus. In fact, many times a dermatologist will refer one of these patients to me because of the concern that there's a systemic lupus. However, it's not a common, it is possible. Again, this kind of rash will often be determined as lupus based on a biopsy, and most of the time dermatologists will manage this. Let's think about the other manifestations of systemic lupus. We already talked about cutaneous lupus. I do just want to point out that oftentimes patients can have hair loss. This can be isolated hair loss or hair loss because of scarring, such as in the case of discoid lupus. It also can be a diffuse thinning of the hair just associated with their chronic inflammation. Systemic lupus often will cause joint pain. This is an inflammatory arthritis. It tends to follow a pattern of being small joint symmetric, similar to rheumatoid arthritis. It's not limited to that. It can affect any joint, but that's the most common pattern. Interestingly, lupus arthritis tends to not cause erosions. So if you get hand x-rays and you see erosions, that's more likely to be either rheumatoid arthritis or gout and less likely to be lupus. Lupus can also affect the bone marrow. or the hematologic organ. Is that an organ? The heme. This can cause any cytopenia. It can cause a single cytopenia, such as an isolated leukopenia. It can cause an isolated anemia. It can cause a combination of cytopenias. It also can affect the blood counts through hemolysis. When you see a patient with lupus who has anemia, especially if the anemia is getting worse, it's important to evaluate for hemolysis because that's going to be treated differently than other forms of anemia. As you know, lupus can also affect the kidneys. And when it affects the kidneys, this predominantly is a glomerular nephritis. When you suspect lupus nephritis, with very few exceptions, we're going to want a biopsy. And the reason for that is there are different degrees or different severities of lupus nephritis and different types of lupus nephritis, which may affect the treatment decision. Now, lupus nephritis is one of the worst, historically worst causes of mortality in these patients. Thankfully, we have many more strategies and medications for treating lupus nephritis. However, if they are not identified and scarring occurs, then they're going to have permanent kidney damage. It's important to think about how a person with lupus nephritis is going to manifest clinically. Usually, it's going to be one of two ways. Because of the protein loss, they may see foamy urine. Occasionally, you'll see blood in the urine, but more often, the patient will complain of foamy urine. The other way that this is going to manifest clinically is that because of the protein loss, they're going to have edema. It might be isolated lower extremity edema, or it may be anasarca. So especially if you have a young woman who has new onset anasarca, think about lupus, make sure you look for nephritis. This is something that we want to treat aggressively and early. The other manifestation we think about with lupus is Raynaud's syndrome. This is not going to be seen in all patients with lupus, but it is one of those diseases where Raynaud's is more common and can be a clue to help you think more about the presence of lupus. As noted earlier, the 5 organ systems that I mentioned are not exclusive. These are not the only ways that lupus will manifest. There are many other manifestations that can come from lupus. Let's look at a few more. Mouth sores are common ways that lupus will manifest. As far as cardiac involvement, the most prevalent form of cardiac involvement is an increased atherosclerosis. And we know that patients with lupus have a much higher rate of cardiovascular disease than their healthy peers. So it's very important to try and get the inflammation controlled and ensure that lupus patients are maintaining a healthy lifestyle. It's also important to check for cholesterol levels and manage cardiac risk the way you would in someone with diabetes. The other more common manifestation of cardiac involvement in lupus is pericarditis. This could also lead to pericardial effusions or even possibly tamponade. What about myocarditis? Can that happen with lupus? Well, the answer is yes. Lupus can do just about anything. It's not a common manifestation, but it is possible. What about the lungs? The main manifestation that we see in the lungs is pleuritis. And in fact, this is a theme with the pericarditis and pleuritis. You can also get a peritonitis, or the broader term for that is serositis. Now, can you get other manifestations in the lungs? For instance, can you get interstitial lung disease? Can you get diffuse alveolar hemorrhage? Well, the answer again is yes, you can, but those are very uncommon forms of lupus. If you see interstitial lung disease, you're going to think about Sjogren's or scleroderma or myositis much before you think about lupus. Neurologic involvement is also present in lupus. It can affect the peripheral nervous system, but not commonly. More often, you're going to see central nervous system involvement. Now, when we think about central nervous system involvement with lupus, this can be a little bit controversial. The experts will go back and forth about what manifestations actually constitute a CNS manifestation of lupus. Now, if someone has lupus cerebritis, they have marked delirium or encephalopathy, then that is not really questioning whether or not that's caused by lupus. But what about someone with depression or someone who has a little bit of brain fog? Is that a CNS manifestation of lupus? Again, it's a little bit controversial, but certainly evaluating for central nervous system symptoms can be helpful in patients with lupus. Does lupus affect the GI tract or the liver? This is a rare manifestation. Again, it can happen, but it's not common. Let's imagine that you have a patient sitting in front of you who's complaining of mouth sores, a malar rash, recently new onset Raynaud's, and joint pain, and you're concerned about the possibility of lupus. What testing do we want to do? Well, as you know, you're going to get the ANA, and you're going to order the test that will automatically reflex to the ENA panel if the ANA is positive. Some other labs that you're going to want to look for that you will often neglect is the C3 and the C4. These are very helpful in lupus because when lupus is active, they often will go low. If the C3 and C4 levels are high, that's harder to really know if they're going to help you. But when they're low, that's usually happening because of consumption of the C3 and C4. The other way the C3 or C4 might be low is that genetically they are predisposed to not making as much of that protein. And interestingly, someone who has a C3 or C4 deficiency is at a higher risk of developing lupus. So if someone has a low C3 or C4 when their lupus is active, and then you treat their lupus and that test normalizes, now this becomes a really helpful biomarker for the future, because now you can use that as something that does fluctuate with disease activity. There are some lupus patients who have a low C3 when they're active, and then when you treat their disease, the C3 remains low. So then it becomes less helpful. But when it's a dynamic change, that becomes very helpful. Oftentimes we'll check inflammatory markers. Now I've listed here the SED rate and maybe CRP. Usually a first time around I'll check both of them, but it's important to note that just like C3 and C4 get consumed in lupus, oftentimes the CRP will get consumed, and therefore you might have a normal CRP but an elevated SED rate. And in those situations it may not be very helpful, but you can check both of them initially. You're certainly going to want to look for any cytopenias. You're going to want to get a metabolic panel to evaluate their creatinine and see if there's any other abnormalities there. A urinalysis is very important because these patients who are developing nephritis are going to have hematuria and proteinuria well before they ever bump their creatinine. If the suspicion for nephritis is high, or if they have a prior urinalysis already showing proteinuria, then getting a spot urine protein to creatinine ratio can be very helpful. Are there other tests you're going to want to do for lupus? Well, I've listed some others here that you might think about. You don't have to do these on every patient, but these are some other tests that you might think about that might cause other autoimmune conditions. As far as the antiphospholipid antibody testing, some rheumatologists do this routinely in anyone with lupus. I don't think I would do it on a first pass evaluation, but if someone has a clear case of systemic lupus, it would be worth testing that to help determine if there is an increased risk of thrombosis. Now, another important point when we're thinking about lupus is, let's say that you are working in an emergency room and a person who has lupus comes in and is getting admitted to the hospital because of a severe illness. Many times these patients look septic, and we don't know if they have an infectious disease or if this is a manifestation of their lupus. Here again, checking a C3 and a C4 level can be helpful for those patients where this is a dynamic test, because C3 and C4 are usually going to go elevated in infection but low in active lupus. So don't forget the C3 and C4. That's enough talk about lupus. Let's now focus on Sjogren's disease. Sjogren's disease has a lot of features that overlap with lupus, and in some cases is very clear to make a diagnosis, but there are times where it's sometimes difficult to know what is the correct diagnosis, either Sjogren's or lupus. I mentioned previously that the anti-Rho antibodies are most common in Sjogren's disease, but can also be present in lupus. So let's think about the 5 most common manifestations of Sjogren's disease, in my opinion. Well, the first one is the dry eyes and dry mouth. That's really a key characteristic of Sjogren's, and it would be very hard to make a diagnosis of Sjogren's disease if the patient was completely asymptomatic with dry eyes or dry mouth. One of the questions that we will ask when a patient complains about dry eyes is how often they're putting eye drops in, or the re-wetting eye drops. People with Sjogren's are putting these in often multiple times a day. If someone says, oh yes, I have dry eyes, but they never use re-wetting drops, they probably don't have Sjogren's. If they're using them multiple times a day, that certainly increases the likelihood that they have Sjogren's disease. What about dry mouth? Many of these patients will carry a water bottle with them and will be sipping water all the time. A question that is often asked: if I were to give you a plate of saltine crackers, would you be able to eat them if you had nothing to drink? And for people with Sjogren's, they'll usually just laugh at you and immediately answer no. Many people who don't have Sjogren's would be able to say, oh, sure, that would be no problem. So that's a helpful question to ask when trying to determine how severe the dry mouth is. Sjogren's disease also will cause an inflammatory arthritis. It also tends to be small joint and symmetric, and again, is very difficult to distinguish from something like lupus. Sjogren's disease often has fatigue as a major feature, and this can be one of the primary complaints for many patients with Sjogren's disease. Unfortunately, we have very little that helps with this manifestation, and the exact etiology for the fatigue in Sjogren's disease is not clear to me. It can be quite a challenge. Sometimes DMARDs help, but not always. But again, a common manifestation of Sjogren's. As opposed to lupus, Sjogren's disease does often affect the lungs, and I will often think about interstitial lung disease in patients with Sjogren's who have any pulmonary complaints. The other way that Sjogren's will often manifest is with a distal peripheral neuropathy. This can affect just the feet and the hands, and again is usually a sensory deficit with numbness or tingling. Many patients who get a diagnosis of a small fiber neuropathy are then evaluated for presence of Sjogren's disease. So this is again a symptom that will help distinguish Sjogren's from lupus in many patients. Just like with lupus, Sjogren's can cause many other organ system involvement, and so it's worth going through the other organ systems that we want to think about. With hematologic, Sjogren's also can cause cytopenias. Now, an important point with Sjogren's is that there is a high incidence of B cell activity. And in fact, many patients with Sjogren's have hypergammaglobulinemia. This is a polyclonal gammopathy, but it's also persistent. For many, this high level of IgG is present throughout the course of their disease. Because of this increased B cell activity, there is a higher risk of lymphoma in patients with Sjogren's. So if you have a patient with Sjogren's who is now suddenly having unexplained weight loss, night sweats, swollen lymph nodes, you absolutely have to evaluate for lymphoma. As opposed to lupus, Sjogren's disease does not commonly affect the skin. When it does, one of the more common manifestations is erythema multiforme. Sjogren's also does not commonly affect the kidneys, but as opposed to lupus, which causes a glomerulonephritis, Sjogren's disease will more commonly cause a tubulointerstitial nephritis. This is going to lead to proteinuria, but not hematuria, and will usually involve a slow rise in creatinine over time. And here again, a biopsy is very essential to figure out where the actual pathology lies. You can see Raynaud's in Sjogren's, although it's less common. For some reason, Sjogren's disease, well, not for some reason, because of the high immunoglobulin levels, Sjogren's patients also have a higher incidence of cryoglobulinemia. So they may get a cutaneous vasculitis, and this could be from cryoglobulins. Cardiac disease is not common, and also GI and hepatic involvement is also not common. However, there is an increased incidence of primary biliary cirrhosis or autoimmune hepatitis in patients with Sjogren's disease. So if there are LFT abnormalities, you want to think about those two entities as well. For patients who have a severe case of lupus or a severe case of Sjogren's, distinguishing one from the other is not always that difficult because of their varying manifestations. However, sometimes it's hard to know if a patient has a more accurate diagnosis of systemic lupus or Sjogren's. And here's an example. If you have a 35-year-old female who has an inflammatory arthritis, fatigue, a dry mouth but not dry eyes, and has Raynaud's, these are symptoms that could be present in either patient. We know that the dry mouth is more common in Sjogren's, and we know that the Raynaud's is more common in lupus. So we have features that could fit in either diagnosis. The ANA is positive at 1 to 320, and they have a positive Rho antibody, which again can be seen in either lupus or Sjogren's. They have a leukopenia and a high sed rate. And if this is the manifestation, it's hard to know what the diagnosis is. Oftentimes what will happen is you start with one diagnosis, and then over time as the disease changes or develops, then you may actually change the diagnosis. So I might start by calling this person Sjogren's disease, but then they'll get cutaneous lupus down the road, or maybe they'll develop a glomerulonephritis, and so I'll switch that diagnosis over to lupus. So this kind of begs the question about why is it important to get the accurate diagnosis? And in reality, if the treatments are the same, it's probably not that important. But patients do like to know their diagnosis. They like to be able to read about the manifestations that could arise. They like to join groups online of other people with their diagnosis. So oftentimes what I'll tell someone is, I'm giving you this diagnosis now, but just know that this could change in the future. Now we're going to talk about systemic sclerosis or scleroderma. You certainly learned in medical school about a diagnosis called CREST syndrome. And by and large, in rheumatology, we're going away from that diagnosis and preferring either systemic sclerosis or scleroderma. However, remembering the acronym CREST can be helpful as we think about the different manifestations that we'll often see with systemic sclerosis. Now, the most prominent is the thickening of the skin. When the skin thickening happens at the fingers, we call this sclerodactyly, and this is certainly the most common and prevalent place for the skin to get thicker and firmer. This skin thickening can happen on the face, the legs, the feet, the trunk, and we're going to see later that the location of the skin thickening can affect the actual diagnosis. Raynaud's is almost universal in systemic sclerosis, and if someone does not have Raynaud's, then you should really rethink the diagnosis of scleroderma. Esophageal dysmotility or severe GERD is also very common. Telangiectasias most commonly show up on the face or the chest, but they could happen other places as well. What is calcinosis? Calcinosis are little firm sores or nodules. These often show up on the fingertips, and they'll get almost a little divot in the skin where a chunk of calcium is just under the skin. Over time, eventually this works itself out and leaves the skin. But these areas can be very, very inflamed and very, very painful. You can also get chunks of calcium or calcinosis deeper in the tissues. This could happen in the wrist or the elbow or in the forearm, and those areas can be very painful as well. Sometimes they're chronically painful, and sometimes they get acute inflammation, almost like a gout flare. And so for some of these patients, we'll treat them with colchicine. Calcinosis is very challenging. It's very difficult to treat, and it's a real challenge for a lot of patients. Other ways that systemic sclerosis might manifest is by having inflammatory arthritis or sometimes just arthralgia without the inflammation. And sometimes these patients can also get myositis. When we think about systemic sclerosis, it's helpful to distinguish between limited or diffuse scleroderma. This image helps you understand what makes the differentiation. It's really the extent of the skin thickening. So limited can have involvement from the elbows down, the knees down, or the face. If you have skin involvement on the trunk, the thighs, the upper arms, then it's defined as diffuse scleroderma. Now, the reason it's important to make this distinction is that there are patterns of different disease manifestations based on the limited versus diffuse. Let's talk about how these two diseases differ. One of the ways that these diseases differ is that they tend to have a different autoantibody profile. Limited scleroderma most commonly is associated with an anti-centromere antibody, whereas diffuse scleroderma is more commonly associated with an anti-SCL70 antibody. Sometimes they'll have an RNA polymerase III antibody. As I have said before, these are not universal. You can have a patient with diffuse scleroderma who has an anti-centromere antibody, but the most common pattern is what you see here. Now, scleroderma commonly affects the lungs. This is often one of the biggest sources of morbidity and mortality in patients with scleroderma. Interestingly, though, the different disease types tend to have different lung manifestations. And as you can see, limited scleroderma more commonly has pulmonary arterial hypertension, whereas diffuse scleroderma more commonly has interstitial lung disease. Limited scleroderma is a less aggressive disease in most cases. They're less likely to have myocarditis or renal involvement, whereas diffuse scleroderma has a higher incidence of myocarditis. And when scleroderma affects the kidneys, they don't usually get glomerulonephritis or a tubulointerstitial nephritis the way you get with lupus or Sjogren's. The more common manifestation of scleroderma is something called scleroderma renal crisis. This is a very important disease process. My experience is that most of the residents that come through my clinic haven't heard of this or don't know what it is. So we're going to spend a little bit of time talking about scleroderma renal crisis because this is something that the internal medicine boards often like to ask about. And more importantly, this is something you don't want to miss because people will die with this diagnosis.
One way to think about scleroderma renal crisis is that this has been likened to Raynaud's of the kidney. Basically, what's happening is that the arterioles that are leading to the glomeruli become narrowed and vasoconstrict and therefore cause local ischemia. This is primarily driven by angiotensin, and often these patients will show up in the emergency room feeling very, very sick. The first manifestation that's most prominent is their hypertension. Usually they have a very high both systolic and diastolic blood pressure, and they are feeling very symptomatic because of that. Usually by the time they present, they have acute kidney injury, and the urine does not have hematuria. It may be a bland urine or there may be some protein present. This process, because of the hypertension, will also often have similar findings as those patients with malignant hypertension, including encephalopathy or heart failure. This process also causes or can cause a microangiopathic hemolytic anemia. This will often mean not only they are anemic, but also they might have low platelets. Often there's also hepatic injury. These patients, if untreated, can go on to failure of organs and death. And so it's important to recognize it in patients with scleroderma and to treat it aggressively. The mainstay of treatment is to treat the hypertension. If we can get the blood pressure down, then most of the time all of these other manifestations are going to resolve and get better. The mainstay of treatment really is inhibiting angiotensin. So ACE inhibitors have been revolutionary for treating scleroderma renal crisis. In this situation, you're usually going to start with IV ACE inhibition. in other words, captopril. We want to administer it quickly and frequently until we can get the blood pressure down. If for some reason the patient does not tolerate ACE inhibitors, then you can use ARBs. And if they're still not responding, then you can continue to add other antihypertensives to try and get the blood pressure down. The last ANA-associated disease we're going to talk about today is MCTD, or mixed connective tissue disease. I really don't want to spend a lot of time on this disease. This is very rarely seen. I don't usually see this in most of my patients. And recognizing the manifestations of the other ANA-associated diseases will help you with this one. Now, I do want to point out that mixed connective tissue disease doesn't just mean it's a conglomeration of a bunch of other diseases. It is its own entity, and this is a specific disease that we will give someone. And this is different from what we call an overlap syndrome. So if someone has features of rheumatoid arthritis and Sjogren's disease, we might call that an overlap syndrome of rheumatoid arthritis and Sjogren's. But mixed connective tissue disease is its own disease process. Now, the easiest way to recognize it is the strong association with a high titer RNP antibody. For many of these patients, in fact, most of them, Raynaud's is an early manifestation, and it's often a pretty severe manifestation. The reason it got the name mixed connective tissue disease is because it does have several features of the other ANA-associated diseases. You can see listed there that there are many features that look like lupus or myositis or systemic sclerosis. Interestingly, for some of these patients, as their disease progresses over time, they might start with more of a myositis picture and then move into more of a lupus picture over time. So this does tend to fluctuate over several years. ANA-associated diseases are not common. We don't see these often, and in your clinic internal medicine, you're not going to see these every day. Most of these patients then are going to end up with a rheumatologist, and the rheumatologist is going to be the primary one managing the disease. So I don't want to spend a lot of time talking about treatment today, but I do want to talk about some of the principles and also help you to know what some of the medication options are. The first point is that hydroxychloroquine is a really valuable medication and almost essential medication for most of these diseases. Hydroxychloroquine especially is good for lupus. And in a recent lecture that I attended at a conference, a lupus expert basically said that anybody with lupus should be on hydroxychloroquine unless they don't tolerate it for some reason. This helps with many of the manifestations, the arthritis, the skin, mouth sores. Hydroxychloroquine is nice because there are actually very few side effects, and this is a medicine that, as an internal medicine doctor, I feel you should be comfortable starting on any of your patients. Dosing is important. The maximum dose is either 400 milligrams daily or 5 milligrams per kilogram. So if you have a petite person, then you're going to go with the weight-based dosing. Side effects, like I said, are very rare. The most common side effect is that someone might have loose stools or diarrhea when they start this medicine, but that almost always clears up in a week or two. There is a diffuse allergic rash that can occur with the hydroxychloroquine. I don't see it commonly. I see it maybe every 2 or 3 years, but it's also really
a very aggressive rash and very uncomfortable. And so you need to warn patients that if they start this and they get a rash, they need to stop their drug right away and let you know. Hydroxychloroquine can cause retinal toxicity. This is mostly in people who are either taking too high of a dose or who have been on it for more than 10 years. So I'm not overly concerned about that problem in the first year or 2 or 3 that I have someone on the medication. However, if they're going to be on it for 5 years or more, then they absolutely need to get annual eye exams. Other things hydroxychloroquine can do include cause a myopathy. This could be a peripheral myopathy or could be a cardiomyopathy. If you're evaluating someone who has a new onset non-ischemic cardiomyopathy and they're on hydroxychloroquine, you're going to want to talk to the rheumatologist about stopping that medication. A warning that often comes up with hydroxychloroquine is that it may cause QT prolongation. This was really only discovered when hydroxychloroquine was being used at high doses for acute treatment of COVID syndrome, and people were having arrhythmias. When using the recommended doses, QT prolongation is very uncommon. What are some other medications that we'll use to treat lupus? Methotrexate or azathioprine are especially good for arthritis or the skin or for myositis. We'll sometimes use these with other manifestations of lupus or Sjogren's. Sometimes they will help cytopenias, but a side effect of both of these medications is causing cytopenia, so that can become a little bit challenging at times. There currently are 2 biologics that are approved for systemic lupus. One of those is Benlysta, also known as belimumab. This is an antibody that targets BLyS, or B lymphocyte stimulator. BLyS is a cytokine that activates B cells, and when this is blocked, is going to have less B cell activity and therefore less inflammation. The other biologic that we have is Safnello. Safnello is also known as anifrolumab. This is an antiferon antibody and also can be very helpful for lupus. These biologics are also being tested in other ANA-associated diseases, but right now the only indication is for lupus. What about the more severe or organ or even life-threatening manifestations of these diseases? Well, as we've talked about, lupus nephritis is a very aggressive and very concerning manifestation of lupus. This is currently treated with triple therapy, high-dose steroids, mycophenolate, and then the addition of either Benlysta, which we talked about in the last slide, or voclosporin, which is a calcineurin inhibitor similar to tacrolimus. What about someone with lupus cerebritis? So if they have MRI changes and significant encephalopathy, this again is someone who we're going to treat very aggressively with high-dose steroids, and you may add either mycophenolate or even cyclophosphamide. Interstitial lung disease, which is going to manifest with Sjogren's or scleroderma, oftentimes what we'll do is we'll start with high-dose steroids to see if they get a symptomatic or a radiologic response. This is going to be usually 60 to 80 milligrams of prednisone for several weeks. If they do get a good response, then the next treatment is often going to be mycophenolate. There are other options, including a biologic called tocilizumab or rituximab, but mycophenolate is a common medicine that we'll reach for. If that person is not getting a response, either symptomatically or radiologically, it may be that they have fibrosis predominantly without a lot of inflammation. In that situation, then we're going to think about the antifibrotic therapies such as Ofev or nintedanib.
And that's all that we're going to talk about today for the ANA-associated diseases. I hope that you're able to have a better understanding about how to recognize these diseases. Oftentimes you're going to have a patient sitting in front of you. They may be complaining about joint pain and fatigue, and you really have to ask yourself, is it likely that this person has lupus or Sjogren's or one of these other diseases? As you recall, the ANA test has a high false positivity rate. It's great for screening, but it also can cause a lot of anxiety because it often shows up positive even without autoimmune disease. So I'm hoping that this helps you to be a little bit more judicious as you think about who is appropriate to order the ANA test. Thank you. I'll see you next time.